Hi doctors, how are you? Welcome to the new week of oral pathology part 2. Yes, oral pathology we studied a few weeks ago, but it's annoying topic and we're trying our best to spread it over a few weeks. We discussed last time about the 5 main concepts that you need to understand about oral pathology and the 3 patterns of the question most likely happen in the exam. You can watch this video. I will put a link somewhere here so you can click it. But today we are trying to connect between the oral pathology and the medical management, because sometimes you see question connecting both together, you feel like this is management, this is pathology. But anyway, it is a question. I would like you to understand how you can tackle it, how you can read the keyword, how you can answer it. Let's not waste your time and start with our first question. A patient present with unilateral vesicle eruption that heals, leaving hypopigmentation scar and persistent burning pain. Oh, I feel bad for this patient. So the key word here is unilateral. So you need to pay attention to the wording, not reading question like this. So the key word here is unilateral and we have burning pain. The most likely diagnosis is trigeminal neuralgia, post-herpetic neuralgia, Bell's palsy, temporal arthritis. Honestly, all 4 conditions might have something like this. So this is why it's critically important to catch the keyword. The keyword will immediately eliminate 2 and give you more idea about 2 conditions. Most likely this will be post-herpetic neuralgia. Why? Because let's see the journey of this infection. While we are kids, usually you end up by chickenpox. If you are so lucky and you end up by this one, please let me know, because I think every one of us have this infection while we are young. It's self-limiting, nothing happens and everything goes usually fine. And then the virus responsible for this is going to stay dormant in your dorsal root ganglia, which the name of the virus is varicella zoster virus. And then this have the same pattern like primary herpetic gingival stomatitis, but for our good luck, for everyone good luck, it has only 1 recurrence. Why? Because the recurrence happened for this one, we call it shingles. So this shingles is going to be unilateral because it's going to go through the distribution of this nerve that lay dormant inside it, and is going to be painful. It's not going to be easy. So here we call it chickenpox in the beginning, and later on we call it shingles. This shingles happened once and it's extremely painful. Back home in Egypt we call it hazam nari because it's extremely painful condition. So what's happening is this. This post-herpetic neuralgia is a chronic neuropathic pain condition that occurs following infection with varicella zoster virus, which cause herpes zoster, which is shingles. Initial phase, it will going to be unilateral vesicle eruption along the dormant, which is like the side where it stays dormant, healing, lesion resolve, leaving scarring or pigmentation change, and the chronic phase, which is rare. This is not the common phase for all patients with post-herpetic neuralgia, where the patient is suffering from persistent burning, aching, or the static pain lasting months to years. According to the patient medical condition, the age of the patient most commonly happen in female old patient with some comorbid condition like diabetic or uncontrolled hypertension. The pain is due to damage to the sensory nerve fiber and usually it's a persistent neuropathic signal. So why not trigeminal neuralgia? Because trigeminal neuralgia, as you can see, we have ophthalmic, maxillary, mandibular, it will be here, and trigeminal neuralgia will not have this pigmentation. Will have triggering point while shaving your beard, while putting some makeup, while touching some teeth inside the oral cavity, and it will be sharp stabbing pain. It will be sharp stabbing pain. So trigeminal neuralgia, sudden electric shock like pain, no vesicle or rash. This is the answer, post-herpetic neuralgia. Bell's palsy, this is facial paralysis, is related to motor. So in Bell's palsy, we have some problem with the facial nerve, but it's a motor function. Patient cannot control his face. And the question telling you vesicles. So unilateral, Bell's palsy, yes, but vesicles and scar, nothing. Temporal arthritis, which is headache, scalp tender, and this has no vascular eruption again. So the answer here is post-herpetic neuralgia. Moving to the next question. A patient present with painless, slowly enlarging radiolucency at the angle of the mandible. Aspiration yields straw-colored fluid. The most likely diagnosis is ameloblastoma, OKC, dentigerous cyst, or radicular cyst. So this is a very common pattern when we're comparing between histopathology and clinical presentation to conclude our answer. So angle of the mandible making you think about these 3. Radicular cyst, we don't have teeth here, so it's difficult to end up by a radicular cyst here. So you are cornered between all 3. Memorization of the histopathology will save you some question. Trust me, memorization of histopathology will give you some question like this one. This is a typical dentigerous cyst, which is a developmental odontogenic cyst associated with crown of unerupted or impacted teeth, most commonly mandibular third molar and sometimes maxillary canines. Oh, let me stop here. This is what we call dentigerous cyst. Why? Because you can see the lesion, it's coming lucency at the crown. If it's at the canine here, how you consider it to be dentigerous or AOT, adenomatoid odontogenic tumor? What do you think about it? Let's see, because this is very important information I would like you to understand. The key feature for dentigerous is painless, slow-growing swelling, commonly located at the angle of the mandible, and in radiograph, it's a well-defined unilateral lucency attached to the CEJ of impacted tooth. And this is the key word to differentiate between dentigerous and AOT. Because the dentigerous cyst, the etiology of it is accumulation of fluid between the reduced enamel epithelium and enamel surface or enamel organ during development. So this separation of reduced enamel epithelium ending up by cystic degeneration, ending up by this fluid and the cavity lined with epithelium. This is the definition of a cyst. In AOT, it will be slightly different because the etiology is different, so the lucency will extend beyond the CEJ, and this is how you can differentiate between both. And AOT most likely will be mixed. It has some radiopacity inside it, and in histopathology, this is why they give it the adenomatoid, which is duct-like structure. Going back to this one, you end up by aspiration, ending by straw-colored fluid, which is protein-rich cystic fluid. So this is where I can understand this is a dentigerous cyst. Did you see dentigerous cyst in reality? This is how it looks in reality. Not like everyone see it in X-ray. This is how it looks in reality. And the treatment for this one is inoculation with extraction of the tooth itself. And as you can see, it's not easy to be done. I remember one of the dentists I used to work with as assistant, like he was like, yeah, let's do extraction for this one. I told him, man, no, we need to refer it to oral pathology because like you would like to cut the bone, get it as much as you can do in one piece, as you can see here. Sometimes if the dentigerous cyst is so big, the treatment will start not by at the end of the day, inoculation and with extraction of affected teeth. Sometimes the lesion is so big, so we do what we call marsupialization. What's the meaning of marsupialization? You see here the lucency is so big, so if you're going to extract this and remove all that, you have huge chance to injure the perioavar canal. So let's relieve the pressure. Exactly, this is the meaning of marsupialization. You're going to open a window, relieving the pressure from this cyst inside because the cyst cavity filled with fluid, applying pressure over the bone. So let's relieve this pressure, which is going to shrink the size of the cyst, and then you can go back to remove it. It's a big cavity here, and as you can see, the root here is almost gone. This tooth also need to be gone, but the chance to injure the nerve is less. So treatment, extraction, and this is extremely important. In a cyst, the treatment is to get rid of it. Look, telling me cyst here in this area, meaning nothing, patient have no pain, nothing. You need to remove it. Why? A cavity filled with fluid eating bone. What you are waiting for? You are waiting for the patient end up by fracture. But when you speak, you do what we call marsupialization. Let's see our other option, ameloblastoma. This is multilocular, soup-like appearance, and this one is aggressive, no straw-colored fluid. OKC, thin keratin filled with minimal expansion, not typically straw-colored. This is have what we call parakeratinized, dentigerous cyst around the crown with a straw-colored fluid. Radicular cyst with non-vital teeth. No vital teeth will be here. Yes? Moving to the next question. A patient taking warfarin required dental extraction. His INR is 4.5. What is the most appropriate management? Proceed with the extraction without modification, stop warfarin immediately and proceed, defer treatment and consult physician to adjust INR, administer vitamin K and proceed immediately. So first we need to understand what is warfarin. Warfarin is oral anticoagulant and it's a very annoying medication because it has narrow therapeutic index, tons of drug-drug interaction, and for your general information, is a rare poison which no one is using nowadays. But for AFK exam, you need to understand. And this is the oral anticoagulant which require monitoring before doing any surgical treatment, which is INR and should be fresh in the same day. What's the meaning of INR? Let's understand the INR before we consider the management. So this is oral anticoagulant, prolonged thrombin time. So patient who is receiving warfarin, he has something, he's not taking warfarin for fun. His medical doctor giving him warfarin because he has the risk of thromboembolism, stroke, CVA, maybe myocardial infarction. So the medical doctor giving him this medication to make his blood being watery. Yes, you hear it carefully. Yes, correctly. This is water blood. Meaning, patient normally when he got injured in his finger, he will bleed within maybe 15 to 20 seconds. It will stop bleeding, the clot start, and everything is fine. This is the normal time. We would love our patient, his blood to be flowy more, so to reduce the risk of this stroke or MI, so we increase the number. So it will be maybe 30, it will be maybe 45. So if it's 45, so it's 3. If it's like 60, it will be 4. So here the question telling me 4.5. So literally this patient has water inside his veins. So the normal number where we can do extraction is less than or equal 3.5. Minor oral surgery can proceed with local hemostatic measure. More than 4, no, we have higher risk of bleeding, and here we have 4.5, significant elevated watery blood. So we have risk of uncontrolled post-operative hemorrhage. So what is your management? Do not stop warfarin abruptly. Why? Because you are a dentist. You cannot stop this medication. You didn't prescribe it, so you cannot stop it because of risk of thromboembolism, stroke, and MI, and patient well-being and being alive is more important than doing extraction. You are not going to proceed immediately. You are going to consult with the physician to adjust oral anticoagulant safely. What is the routine or the rationale for adjustment? To get his blood to be slightly bloody, not watery, so the coagulation system is working. This is the management for the other, like aspirin and heparin. Please read it carefully after this, and this give you answer for very annoying question. Maybe you know this question, so this is the answer for the annoying question about aspirin stopping. Let's go to warfarin. Warfarin, and the other name is Coumadin. Please know the other name, because sometimes you will see the question giving you this name, and you don't know it, and you lose the question. So the normal here is between 2 to 3. If it's 3.5, we said it's fine. But if it's more than 3.5, like this question 4.5, we need to be more careful because we cannot do extraction. The medical doctor will stop it, and it will not kick immediately. It will take usually 2 days before surgery. So the medical doctor stop it. After 2 days, you measure INR. It's fine, falling to the normal range, which aiming for 2 to 3, maximum 3.5. Fine, you can do extraction, and the patient will continue warfarin on the day of the surgery. Okay, so proceed directly. Good luck. You are going to end up by severe bleeding after doing extraction. It's 4.5. Stop warfarin. You are just a dentist. You are not going to do that. Defer and consult. Yes, adjust INR safely. I don't know what's meaning of safely, but like anyway, it's his liability, not yours. Vitamin K immediately. This if it happened, you did extraction and you go to hospital and his blood is getting so crazy watery, so you're going to do vitamin K to try to reverse the warfarin you did not stop. So the management here is defer treatment and consult a physician to safely adjust the INR. Next question. A 62-year-old patient on a long-term bisphosphonate therapy present with exposed necrotic bone in the mantle following extraction. There is no healing after 8 weeks. What is the likely diagnosis for this one? Chronic osteomyelitis, osteoradionecrosis, medication-related osteonecrosis of the jaw, which is MRONG, or fibrous dysplasia. The question is easy and the answer is C, but I would like to invest some time to understand this condition and the management for this condition. But first, before we understand this, we need to understand what is bisphosphonate. So this condition is a serious complication associated with antiretrospective drug. What is this medication? Like bisphosphonate, alduronate, zelduronate, and dinzizimab. Please know the names. They promise they will give bisphosphonate, but just in case if you see these names, so you should understand what is this medication. Some patient, like patient who has osteoporosis, patient who has hyperparathyroidism, patient with Paget disease, he has imbalance between osteoclast. The osteoclast getting so active, so crazy, cutting the bone, so the bone remodeling is retarded. The bone remodeling is impaired. Patient cannot heal easily. Okay, this is the definition of this medication. And why we give it? Because the patient has a condition where his osteoclast is crazy. And this done through the signal of Rankel system. Amazing. What is the diagnostic criteria? Current or previous medication of this one. When it's IV, is higher risk. When it's oral, lower risk, unless it's oral for very long duration. But when it's IV once for life, this patient is at risk. What is the other diagnostic criteria? Exposed bone more than 8 weeks, and this number I will show you in the reference, and no history of radiation therapy in the jaw. Patient taking this bisphosphonate to control his condition. Bisphosphonate through Rankel system kill osteoclast, literally. So in like fancy term, they call it apoptosis, which is boom, self cell death programmed. So it go to the osteoclast with the Rankel system manipulated, let the cell to be dead, which is not working. So you eliminate osteoclast and osteoblast still here, which is restoring the balance between both. So you are reducing the bone turnover, which is going to end up by impaired healing after trauma, like extraction, and bone necrosis because there is no healing happen. Most commonly affected mandible more than maxilla, and this has very simple reason. In mandible you have cortical bone, less blood supply, and it will be taking more time to heal, unlike maxilla, cancellous bone, more blood in this area, and usually happen after dental extraction or trauma. Let's go to the critical part, which is the treatment. You need first to understand the stages, because if I'm telling you the treatment, you feel like, what? This is not real, but this is how we are going to conclude at the end. So first, patient taking oral bisphosphonate to do extraction for him. He came back later. He has some pain here. Oh, nothing. You take x-ray, no exposed bone, nothing. You let him be and let him understand this. Patient come later. Evidence of necrotic bone, non-specific clinical finding, radiographic change, maybe some lucency, some symptoms here. So again, some just pain medication and antibiotic if he has systemic manifestation or immunocompromised. Other than that, we don't jump to antibiotic. Okay, let's go to the real deal, stage 1, 2, and 3. Stage 1, where we have exposed necrotic bone or fistula that probe to the bone in patients who are asymptomatic and have no evidence of infection. Can this happen in real life? Yes, it can. You will see it, trust me. You will see it in Canada, a lot of very weird condition, but you will see it. Asymptomatic and no evidence. What you are going to do? Antimicrobial mouth rinse, clinical follow-up on quarterly basis, patient education, and make a phone call with his medical doctor. Stop it. He will tell you, you are a dentist. I will not stop it. Deal with your problem. So here we have exposed bone. We didn't cut. We do nothing. Moving to next stage. Patient come after some time, exposed or fistula that probe to the bone with infection, pain, erythema in the region of exposed bone without pus, Caesar management, oral antibiotic, because here we have some systemic manifestation, oral antibacterial mouth rinse, pain control, and debridement to relieve soft tissue irritation. Do you see any cutting of the bone? No. Do you see any cutting of the bone? Not yet. Here you have without drain, without pus, exposed bone, patient has symptoms, antibiotic, painkiller, and that's it. When you are going to cut bone in this stage, when the exposed and necrotic bone extend beyond the region of alveolar bone, the full thickness ending up in the inferior border, ramus, getting in maxillary sinus, zygoma, ending up by fracture or extraoral fistula, yes. Here you need to cut bone and resection. And this has a very simple reason, and this is why I invest some time to discuss the condition. Because you know this patient has retired healing, he has impaired healing because of medication he's using. So if he come in this stage and you cut bone, so what you are doing here, you are complicating the condition for the patient. But here he's going to be dead. So I would have better have patient with like compromised condition, resected bone, and alive, better than patient being dead with systemic infection. And the number for 8 weeks is here. Exposed probable bone and maxillofacial region without resolution longer than 8 weeks, with patient history of taking this medication and no history of radiation. Okay, so this is the condition. This is the weed management. I know most of us when you hear the manager to feel like, no, this makes no sense. I will cut the bone, and this is the rationale. I hope now we have some context, not just memorizing the answer. Chronic osteomyelitis, infection with pain and swelling. He didn't mention any infection here, and we have history of medication. Osteoradionecrosis, no history of radiation. This is the condition, exposed more than 8 weeks with history of bisphosphonate. Phallus dysplasia, ground glass and x-ray, and is a developmental condition, no necrosis or exposure. So the answer here is MRONG, and please understand the management because this will save you some question in the real exam. Moving to next condition. Which of the following best describe an abscess? You feel like this is very basic question. I'm not in grade 2, not in college to ask this question, but they increase the percentage of basic knowledge that you need to understand. You need to memorize this concept, and honestly, it makes your life easy when you go to management later. But if you don't eat this, please eat. You will see some question as a basic knowledge. In our course, we are spreading this information between material because if I'm giving you 1 week to discuss about basic knowledge, I think most of you will just think about ADAT exam and run from the AFK. But let's go back to the question. So he's asking about the description of abscess. Diffuse spreading infection, localized collection of pus, chronic granulomatous inflammation, or viral infection of soft tissue. I think this is easy question. The answer is localized collection of pus, but let's understand what's happening here. So abscess is defined as localized accumulation of prevalent exudate, which is pus. What is pus? So you have tooth with a big cavity close to the nerve. You then deal with it, ending up by inflammation. There's pulp necrosis, ending up by pulp being dead. So your tooth now in a very critical condition. It has soft tissue, which is not viable inside the tooth, which is going to end up by infection. So your body would like to get rid of it. So he will send neutrophils to liquefy the soft tissue, ending up by this prevalent exudate, which we call pus. So what is pus? Dead neutrophils, which did work to liquefy this one, necrotic tissue, bacteria, which was inside the pulp, and protein-rich fluid. What is the pathogenesis? We said bacterial infection, acute inflammation. You then deal, they called neutrophils. Neutrophils liquefy the tissue, ending up by pus-filled cavity. Clinically, you will have a swelling and pain and fluctuant and sometimes drainage, which you call like fistula, which you call perilous, you call it gumboil, whatever you want to call it, but this is how it happened inside the oral cavity. Okay, the first definition, diffuse spreading, this is the cellulitis. And the localized pus is abscess. I have one question for you. What is the factor determining a patient ending up by abscess or ending up by cellulitis? If you know, let me know in the comment. Granuloma, which is chronic inflammation, require macrophages, not related to neutrophils. Viral infection, it will have no pus because we don't have bacteria, because as we can see, this is the pus. We have other type of necrosis that you need to be aware of. If you would like to let me know so I can explain about the type of necrosis, and this is very important topic. I would like to cover it with your course, with your material. If you would like me to explain it, let me know. I can explain this type of necrosis. Finally, the answer for this one is localized collection of pus. And for this patient, what you are going to do, open and drain. What's the meaning of open and drain? You can do pulpectomy, consider it as open and drain. You can cut the gum and give a fistula artificial fistula to drain the pus. But you are not going to give antibiotic unless he is immunocompromised or has systemic manifestation. Fever, lymphadenopathy, trismus. This is the systemic manifestation to give the antibiotic for the patient. Otherwise, just open and drain. That drives us to the last question of today. Finally, we are getting rid of oral pathology slowly. We have one more week for oral pathology. I hope now you can correlate the oral pathology to management together, because I don't want you to be stuck in the exam. This is oral pathology, this is management. This is a question that you need to answer. When you break it down just to make it easy. But at the end of the day, you're going to solve 200 questions in the real exam. Next week, hopefully, we are going to have restorative material, which is going back to dentistry, going back to clinical question. See you next week.